other two girls can't be in the room with patients. They had those.
Oh, I didn't know that.
We didn't know. They found out today, so she'll be handling this.
Okay.
Okay. And we're
ready to roll, huh? That's at 1:35 already. Thanks for coming, Cayleigh. All right. I guess we are live. Welcome, everybody. My name is Steve Beckvar. I'm the Executive Director for the ALS Association. Thank you for being here today. Before we start our presentation, want to acknowledge Life Pro. Certainly, I don't see Bill in the room, but Heather, thank you so much again for opening up your beautiful meeting room for us. We were here before. What a great setup and great and easy to get to for all of us. We're very fortunate to be able to offer these opportunities, and we're excited today from the UCSD clinic to have Cayleigh with us to talk about nutrition. And then we're also excited to visit with MT Pharma. Arlene, I know we haven't met, but we've met with your staff, and to have your presence here as well is appreciated. We've got some information in the back of the room for some upcoming events and activities with the ALS Association, but the agenda is pretty full. So with that, I'm going to turn it over to Cayleigh. Cayleigh, thanks for being here.
I'm live? All right, awesome. So combing through what's real, what's fake, that's pretty much my job. So a little background about me, I went to Washington State University to get a degree in cell biology and genetics, and then I decided I want to be a dietitian. So I went to Bastyr University up in Seattle and got my master's in nutrition. Still sound off? Yeah. Okay. Okay. I'll tell you about my history. How about that? So I went to school up at Bastyr University, and that's where they really kind of teach you as a dietitian how to comb through what's real and what's not. So I'll try to always be kind of clear on what we feel very confident about, what we suspect, and what I simply can't recommend because there isn't any evidence. And then I can tell you what's safe to go ahead and try, even with the lack of evidence, and what's not safe, what's kind of a bad idea. So with that, let's get started. This is the ALS multidisciplinary clinic team. It takes all of us. As I go through this presentation, you'll see that I am not an island. In order to get the good nutrition, I have to work with speech. I got to work with occupational therapy, physical therapy. I have to work with the patient. I have to work with the caregivers. Dr. Ravitz is our director. Keith, I have to work with Keith, ALS Association, of course. So there's me. There's a little arrow just in case you weren't sure I cut all my hair off. So that's our clinic. So what do I do in this clinic? So my main function is to perform what we call a nutritional assessment. And my biggest role in this clinic is to identify malnutrition. I see people about every 3 to 6 months, and that's a good time frame to really detect early as possible when malnutrition is trying to develop. The other thing I do is I figure out individual needs, and I make recommended changes in the diet to assist in you meeting those needs. A big part of what we do is working with speech therapy, and we'll change the consistency of foods if needed and liquids, depending on swallowing function, what's going on. Another role I have is guiding people on the use or perhaps abuse of vitamins, minerals, and supplements. That's an interesting aspect of my job because that's when it starts to intersect with the role of the physician. So I try to be fairly conservative, and that's when I really get into what's safe and what's not safe, and you make your decision based on that. So finally, I work with the doctor to figure out the timing of perhaps G-tube placement. So I would be remiss if I didn't talk about feeding tubes, because that often comes up in the course of this condition. So I work with all team members to figure out what the patient wants and how do we meet those needs. If you're looking for an interesting article, I have a website there. It's from a magazine called Today's Dietitian. It's obviously a magazine for dietitians, but if you really want to get into the nitty-gritty of what a dietitian does with ALS care, this is a great article to go to. Malnutrition. So the reason that I focus on malnutrition in this clinic is, first, it's very common, but secondly, that's one of the few things that we know about nutrition. When you have malnutrition, you have poorer outcomes. So my job is to do everything we can to prevent it and treat it appropriately. So we know that malnutrition, it's been shown to be a prognostic factor in survival for ALS. So those who are malnourished have, let's call it, a 7 times increase of likelihood of death. So weight loss, malnutrition, and dehydration, these all also contribute to muscle and respiratory weakness. So that's why I work with also the respiratory therapist. So if the respiratory therapist is telling me, so-and-so is having some difficulty breathing, we're intervening in this way, I know if you're having trouble breathing, you're burning a lot of energy just to be breathing. So I know we need to be a little more aggressive with what we're doing with nutrition. So we have also found in other studies that even if you don't technically meet a malnutrition criteria, and I can go into that whole criteria if we like, but even if you just have weight loss and you're in a lower BMI category, body mass index, we know these are negative prognostic factors for survival in ALS, so we kind of predict a shorter length of life. We know that it's extremely prevalent to have decreased energy intakes. So the RDA is our recommended daily allowances. So for each age group, they say, hey, we think over 50-year-olds, females, you need about 1,500 calories a day. And they find that in 70% of ALS patients, they're not able to meet those needs. And so why is this? There are lots of reasons for weight loss and malnutrition. One of them is dysphagia, difficulty swallowing. We work with a speech therapist to figure out what textures are the safest for swallowing, and then we figure out how to get the maximum amount of energy and nutrition into those bites. The other thing is, like I was saying, if you're having difficulty breathing, you're burning a lot of energy. Poor appetite is really common, and part of that can be you're less active than you used to be, you're out of your kind of normal routines. And depression, too. Often a very common side effect of feeling depressed is loss of appetite. It can also be difficult to feed yourself if you're having any kind of limb onset or limb involvement of this condition. It can become difficult to feed yourself, and there are people who are, they want to feed themselves. They don't want to have to ask others for help. Very understandable. There's also definitely at play here things we still have yet to discover going on that's specific to this condition. So we know that there are some things going on metabolically inside the body that's causing your metabolism to really rev up. And so we're not sure what's going on, but we have some hypotheses, have some guesses, and that's, we think, the muscle spasms, dystonia, the muscle fasciculations, increased respiratory effort, and then hypermetabolism caused by perhaps maybe underlying mitochondrial dysfunction, some cellular dysfunction, and oxidative stress. And all of that just means your neurologic system is working really hard, and so it's burning a lot of energy. So this is our goal here. We want everyone to do what we can to maintain a healthy body weight so that we can preserve your body's highest level of function, muscle strength, and endurance. Yeah.
All this information are
I am very happy to share this with everyone. Yeah.
Yes.
Okay, good. Great. You didn't want to write down every web address that comes up. All right, all right. All right. So when you come into the clinic, I'm going to ask you a lot of questions that you'll just be like, what are you doing? Why are you bothering me with this? And so I'm here to tell you why I'm asking you these questions. So the first thing I do when you come into the clinic is I assess a weight history. And we can go back pretty far. I want to get a real thorough idea of when you've become hypermetabolic at any point since we think the disease onset occurred. So I don't want to know just in the last month have you had weight loss. I want to go back to when you first maybe discovered some weight loss. Weight gain is also a possibility, but I'm focusing on weight loss because it's just much more common. A little tidbit here, studies have found that those with a higher BMI and an overweight category, it predicts longer survival. So this is, some people think this is fabulous news. We keep hearing over and over, lose weight, lose weight, lose weight, lose weight, and then I come in, I say, please do not lose weight. Don't lose weight. Stay where you are. Yeah, absolutely. Oh, I'm getting to the chocolate slide. We'll get there. I also want to know about appetite changes because that gives me an idea of what we might need to prepare for. If you come to me with a very poor appetite, let's get ahead of things and think about ways to maximize every bite that you're taking. So if you don't feel like eating much, maybe you don't have to eat as much, but we'll still sneak in those calories and nutrition overall. I also work with the speech therapist for chewing or swallowing difficulty. One of the things we've noticed is difficulty drinking water is sometimes the first sign of dysphagia. Sometimes we ask you about, is it difficult swallowing pills? It's not such a great question always because some of us just at baseline have difficulty our whole lives swallowing pills. So the water is kind of sometimes a more powerful indicator. So it's just worth keeping an eye on and letting us know if you notice any differences. When we're working with the speech therapist, they individualize their recommendations as well. But some of the more common recommendations are tucking your chin, adjusting your head positioning with swallowing. Small, frequent meals are very powerful for not only sneaking in calories, but also reducing the amount you're swallowing at one time. It's good to minimize meal distractions. Oh, everyone needs to do this. I don't care what's going on. Everyone needs to minimize mealtime distractions. We're a culture that watches TV, listens to the radio, or on your phone. Being able to just be present with the meal is helpful for all of us, particularly if you have this condition. The dry, hard, crumbly, or irregular consistencies are definitely the most challenging. So chips, those can be really difficult. Mixed textures are difficult. Moistening foods with gravies, again, this is the good news here. Gravies, butter, oil, sauces, chocolate if it's a dessert. That can create a smoother consistency and also be sneaking in nutrition. Liquids can be particularly problematic because liquids go down your throat so much faster than solid foods. So sometimes we recommend thickening liquids, so it's more of kind of a milkshake consistency, and that slows down the speed of the liquid going down your throat, and it's easier to swallow. All right, so other difficulties that come up are functional impairments, difficulty with self-feeding. It could be either because of muscle weakness or fatigue. So we work with occupational therapists and physical therapists. There are excellent websites that sell various adaptive equipment. So for example, spoons with large handles. Sometimes just that's a little easier grip for people. So our physical therapist, our occupational therapist can individualize recommendations to make it as pleasurable and enjoyable eating as possible. One of the things we see a lot of with this condition is constipation. So We're not really sure why this is happening as often as it is, but we certainly guess that it's because of decreased activity and diminished function of the diaphragm. So what do we do about it? So the first thing we want to try is fluids and fiber. We want to go with the natural methods first. If that's not working, we move on to laxatives, but we only want to do that if it's ineffective. Your body can sometimes adapt to the use of laxatives, and we try to avoid dependency on these things. But very common, people are not getting enough fluids. So let me back up a little bit. If you're noticing you're suffering from constipation, think about fluids first. Number one, increase your fluids. Number two, you can increase your fiber. But if you increase your fiber without increasing fluids, you're going to make it worse. We really need that water to mix with the fiber to get things mobile and going. So fluids, number one. You can shoot for 2,000 milliliters a day. If someone were handy with Google, I think that's around 64 ounces a day. That's usually a good estimate. All right, so this idea of hypermetabolism, just the fancy word for burning a lot of calories, more so than the average person. This is an early and persistent phenomena in this condition. Around 50% at least of ALS patients are hypermetabolic, and 80% of these patients show no change in metabolic status over time. But I've seen everything. I've seen hypermetabolism, and all of a sudden it slows down and people are kind of suddenly gaining weight. So anything is really possible in these cases, but this is what's most common, is to be very hypermetabolic and just to be burning so much calories for the duration. So, excuse me. We predict that the amount of calories you need is increased by 10 to 20% at least from the average person. We think that the mitochondrial dysfunction aspect of this disease might have a big role to play in this. We can dive into that a little bit later too. When you're online, you might notice these websites telling you that they can estimate how many calories you need in a day. And this is actually a very common tool for dietitians to use in the hospital for sick patients. But it's worth noting, none of these equations you're seeing online are actually validated for this group, so don't bother with them. Don't worry about it. It's going to tell you that you need a lot less than you actually do. I guarantee it. Calories we predict, if we want to get into numbers, typically I recommend 30 to 35 calories per your kilograms. So if you want to multiply the kilograms you are by 30, that's usually a good place to start. I don't recommend living by numbers. Maybe for a day or two, it's fun for you to track how much calories you're coming in, but forget it. Doing that every day, no thank you. So really what we look at is what is your baseline intake and how can we increase it, and then we keep trying to modify and increase until the weight stabilizes. That's the easy way. Protein, we estimate you need about 1 gram per kilogram of your body weight. We go up to 1.5. I often go up to 2. So if you want to times your body weight as it is in kilograms by these numbers, that can get you an idea of how much protein you'd like. Let's see. And then the feeding tube placement. So the PEG is just a fancy word for a feeding tube. It's a tube that's inserted into the stomach. It sits outside the body, and you're able to provide yourself tube feeding formula as your way of getting nutrition. So this is a very individualized decision. You will talk with your doctor, your nurse, your speech therapist, your dietitian, your respiratory therapist. We can all come together to give you the information to make an empowered decision if this is right for you. So speaking of the G-tube placement, we don't have a ton of data on this. It does suggest prolong survival. A degree of survival advantage is uncertain. So I certainly can't tell you, if you have this tube placed, we estimate you'll have 6 more months to live. We can't give you a number, but we do find that it does prolong survival. There's no evidence regarding the impact of having a feeding tube on quality of life, and that's why this decision is yours and yours alone. So when do we suggest considering a feeding tube? And that's when people are having some dysphagia, difficulty swallowing with significant weight loss. Sometimes there are cases where the weight loss is so severe and it's so difficult to keep up on it that placing a feeding tube is a relief, and you're able to meet your calories through a prescription, the amount of cans of tube feeding formula you need, and it alleviates some stress for some people. So if we're noticing a profound amount of weight loss, this is something we consider, depending on the entire picture. We also want to take a look at respiratory values. Should you choose to have a feeding tube placed, we want to make sure it's safe for you to place it. So you'll notice you'll see a respiratory therapist. They take all these numbers. One of the numbers is the FVC. It's a forced vital capacity. And when it's getting towards less than 50%, we want to think about placing that tube first so that we know this very simple procedure is done as safely as possible. There are some people who have the tube placed not for eating or getting nutrition at all. For some people, it's their way of getting enough hydration. For other people, they use it just to be providing medications. And sometimes people get it because eating is just not really a fun thing to be doing, and it's very tiring. There are many reasons people do not get a feeding tube placement. There could be a fear of side effects. There's a slight risk of infection at the tube site. Really, we see that if you're unable to care appropriately for it. There could be some pain or discomfort at the site of insertion. We know that it does not prevent the progression of this condition. Some people feel a lack of control over the disease, and so they do not want to intervene in this way. Some people live to eat, others eat to live. And then the severity of the respiratory impairment, too, is something to consider. So if you do get a feeding tube, there are certain formulas that the dietitian will recommend. This slide was adapted. It was for a dietitian presentation, so I have a bunch of silly Medicare codes in here that are pretty boring. But basically, you don't need a specialized, expensive formula. We know that a good fiber-containing formula is perfectly adequate. Okay. There's also this new concept of making home-blended tube-feeding formulas. Some people want to be continuing to take in the food that they always have, or they want to personalize their tube-feeding regimen. And so, full, complete disclosure, I have not had patients yet that I have guided in this. This is a very new concept for adults. It's been very common in children with feeding tubes, but have created a handout. So if people are interested when they come to see me, I can certainly guide you in this experience of creating your own tube feeding formula from home. Why do people want this? It's because some people desire natural and whole foods. You want flexibility in your diet, you want fresh, you want seasonal, you want unprocessed foods, and you want a range of phytonutrients and fibers. Those are all reasons that you can consider blending things at home. It's a lot of investment. It's a lot of investment in time and effort. There are some people, in rare cases, we found they don't tolerate the commercially prepared formulas, and what I mean by that are the tube feeding cans you see that are made by perhaps Nestle or Abbott, and some people, for whatever reason, they don't tolerate those formulas. So switching to home blended tube feeding has been found to reduce GI intolerance, issues like reflux, constipation, diarrhea, nausea, or abdominal cramping. Again, this is all found in children. No evidence from adults, but sometimes I like to be bold and just take data from kids and extrapolate it to us. I consider us all humans. So sometimes it's not appropriate to do home blended tube feeding. If you're in the hospital, we wouldn't want you to do that. Risk of contamination of your home blended tube feeding. Other reasons here. If you're interested in this, here are some resources to get you started. And there are also companies who have noticed this desire. Patients want home blended tube feeding, but you simply do not have time to blend it at home. So there are companies who are making their own whole food-based blends. These are just some of the products, and you get a little cost comparison here. It is challenging at this point in time to get these formulas covered by insurance. Often you have to pay out of pocket for these formulas, so I like to be upfront about that. I think that's a shame, and I think the direction we are headed is having all of these formulas covered by insurance. We'll work to get there.
So liquid hope.
Yeah.
$2, whatever that calories. How much is that per day? It's like 3,000 calories a day.
Gosh, good question. Oh man.
Unaffordable or? Oh, sorry.
You know, the question of affordability is always a tricky one. I don't know what's affordable. It's different for everyone. I'm hearing $60 a day. Yeah.
How much?
60.
Yeah.
Oh, $60 a day for Liquid Hope?
Yeah. I'd have to, they have a,
Okay.
I could certainly edit this PowerPoint presentation before
Just
we
to
send
put
it
it
out and
into
answer that
layman's
question.
terms, yeah.
Absolutely.
Thank you.
Yeah. Anyone who's quick on the phone here with Google, if you look up Liquid Hope, they have a great webpage, and they'll be able to get that info quick. Let's see. All right. Finally, I'd like to talk a little bit like supplements. We doing okay on time, Keith? Awesome. So supplements, like I was saying, that gets me into the area of the doctor. So we kind of work a little bit together on this. But we understand the desire to be using supplements to see if there's anything at all we can be doing to increase quality of life, longevity. Your first place you should go if you have questions about a supplement is the fantastic website ALS Untangled. This website is fantastic. They've done, it's based on voting. So if you vote for a topic and it gets enough votes, a committee of educated professionals, they comb over the literature and they give these letter grades as to A, this is a reasonable thing to try. I forget their scoring system, but basically it'll give you an idea, is this worth my time and money? I want to bring your attention to an awesome article. I believe it was a neurologist with UCSD. He put it out. This article is called Nutrition and Dietary Supplements in Motor Neuron Disease. This is a wonderful resource. If supplements is something you want to get into, he has a list of reasonable and safe supplements you can take. So the list here, this is what I haven't seen a lot of. Vinpocytine, I have trouble pronouncing it, that's how little I've seen this. But I guess there's some indication that it could be helpful in some upper motor neuron diseases. Here's the recommended dosage. Vitamin E at this dose is perfectly safe. It's an antioxidant. Oh, go ahead, sir. Great question. So
For the webcast, can you repeat the question, please?
Oh, yes. So do any of these supplements listed require a prescription? They do not. So I'm glad you've asked that, because the way that dietary supplements are regulated in the United States is interesting. So unfortunately, there is not a lot of oversight of this, and this is why I am extremely cautious in recommending supplements, because what's on the bottle is not entirely necessarily what you're going to get. So it absolutely behooves us to go to a company that is has a great reputation, has certificates of compliance, of excellence. And so when people are interested in supplement and they ask me for a brand, I provide a little bit of guidance as to what to look for in terms of those certificates of excellence. So if you're interested in dietary supplements, it was the Dietary Supplements Act of 1994. Yeah, you could look up what that says. John Oliver, I know he's a political humorist, but he did a really fantastic video on dietary supplements. So if you're interested in that, he's on YouTube. Vitamin D is everywhere. Vitamin D is a super safe supplement to take. A minimum of 2,000 units these days is recommended. CoQ10, I'm sure a lot of people have heard of CoQ10. Perfectly reasonable dosage. They have recommended melatonin for sleep. Creatine, interesting. I say may in italics because it may combat motor neuron loss. I have many, many studies showing no effect. So perhaps for some people, spending the money on food to getting your source of amino acids and protein is the way to go. Alpha lipoic acid also found helpful, but this is in mice. But again, it's perfectly safe. L-carnitine also found to be perhaps supportive. And so at this point, I just would love to hear your questions, and I will do my best to answer them. If I can't, I promise to get back to you. Yes, sir. Oh, sorry, just one moment, sir. I think we'll get the mic going.
Okay. So one thing that we've done with Betty, my wife, is she's into 5 years now with the disease, and the progression has been fairly slow. Maybe we're lucky, you know what I mean? Because luck has a lot to do with it, who you are and all that stuff. But something that we did early on is we went for limiting the casein and the gluten on her diet. And, what is your thought process on that? We thought it helped.
Yeah.
You know what I mean? But what's your thought process on that?
Yeah, thank you. So when we think about diet restrictions, we want to make very individualized recommendations. So first I'll start general. So generally for this condition, we recommend liberating your diet as much as possible, and we recommend no dietary restrictions. And that is simply to combat the element of malnutrition. So we've noticed that when people limit their diet in some new way, you lose weight. And it doesn't matter what you limit it in. You take something out of your diet, you don't replace it, you're inevitably going to lose weight. Very difficult to regain that weight once it's lost. So generally we say no restrictions because we want all foods available to you to be as well nourished as possible. Now, when people come to me and they say, I've eliminated gluten from my diet and I feel fantastic, I say, congratulations, that is outstanding, and I'm going to support you in that. So if people come to me and they say, I feel better on this type of diet, fantastic. Continue to follow that diet, and then we will have a conversation about making sure you're still meeting your needs. So you've eliminated casein. What have you increased in your diet? Healthier sources of fats. Maybe she's eating a lot of avocados now. Something we just consider, what are we going to replace that with? Yeah. Does that help answer your question?
It's kind of a follow-on question. So I've learned a little bit about being a fat burner versus a sugar burner, and how does that play into an ALS diet? Would it be better to burn sugars, have more of a carbohydrate-based diet, or is it better to have a fat-based diet where you have fat and protein, which is a longer, slower form of energy?
Yeah, that's a great question. So we know that there's alterations in metabolism. We just don't know if there's a macronutrient, so carbohydrate, protein, or fat, if having a diet higher in one of those things is the way to go. So this is the part where I tell you we don't know.
Okay.
We don't know, but I think you're also maybe kind of getting close to the ketogenic diet question.
Mm-hmm.
So those on the ketogenic diet, it's difficult to meet your needs, and we certainly wouldn't want you going into true ketosis, which is where your body is so deprived of carbohydrates that you basically go into a hypoglycemic episode, and nobody wants to experience that. Yeah. So I can't tell you what specific macronutrient might be helpful to eat more of. At this point, we just recommend yeah, we recommend a well-balanced, healthful diet. So if we're going to talk about carbohydrates, make those carbohydrates work for you. Make those high-quality carbohydrates, fruits, vegetables, whole grains. Make those fats, high-quality fats, avocados, plant-based oils. I've seen some people on ketogenic diets who eat bacon strips and strips and strips and strips, and they have no variation in their diet. I don't think that's probably the healthful way to go. Yeah. Yeah.
Thank you. Yes.
I see some in the back.
Okay. One last question. Okay.
So this may be basic and other people may understand it, and perhaps if that's the case, you can just refer me to something to read. But you spoke about you were talking about nutrition in general, I think, and you spoke about the mitochondrial dysfunction aspect of the disease. And I don't think I know what you mean by that.
Yeah, thank you. Yeah, so as we learned, as some of us learned in school these days, they're always telling kids mitochondria is the powerhouse of the cell. So the mitochondria within our cell is working to provide us our energy. And so we suspect that there might be something going on with the mitochondrial that's contributing to this disease. Now, there are many, many, many other areas that research is looking into, and this is just one of them. But for me, it comes up in nutrition, because if we're talking about mitochondrial dysfunction and we think what's going on is oxidative stress. So what I mean by that is the cells are creating free radicals, damage to the cells because of this. If it's causing oxidative stress, we want antioxidants to combat that stress. And so that's when we get into recommending very healthy sources of carbohydrates. Yeah. So to combat mitochondrial dysfunction, oxidative stress, we want antioxidants, fruits, vegetables, whole grains, healthy fats, proteins. Yeah. Thank you.
All right, let's hear it for Cayleigh. Thank you so much, Cayleigh. So as we transfer over to Arlene, and I'm not sure if this is a Cayleigh question or not, but one of our partners is Papa John's Pizza. And we have Papa John's in the back. Now, I'm not sure we're going to blend it today, but if you're hungry, we don't want malnutrition.
Absolutely.
So plenty of Papa John's, and I would even suggest, is it okay to have them, let's do that right now then. I also want to, I acknowledged earlier, and he wasn't here, but I want to thank Bill Zimmerman again for offering up your room. Thank you, Bill, for having us today again. I appreciate it. There is information in the back, too. There's an event coming up July 29th called Striking a Chord. It's a musical benefit at Qualcomm Hall on the campus of where the Qualcomm Business Complex is. There's a family who's very engaged with music. Unfortunately, their Aunt Margie has ALS. But this is a free event for all of our ALS families and patients. It's a wonderful, they did it 5 years ago. It was a wonderful event. They're bringing it back again. So July 29th, please feel free to take a brochure, a card that explains the details of the event. We have that in the back. We'd love to have you attend. We would only ask that you call us or RSVP to us so we can keep the numbers in order. We expect a great, great turnout for that event. Also with us is Gil from UCSD in the clinical trial program. So Gil, thank you for being here. And there'll be information with Gil, for Gil, if you have an interest in clinical trial information. Gil, did you want to express anything in more detail?
Just to let them know that there's clinical research opportunities with the UCSD Clinical Research group with Dr. Ravitz. In addition to working with Cayleigh and Keith at the clinic, I would go in to talk to prospective patients to let them know about the clinical trials opportunities. Right now, unfortunately, there's only observational longitudinal trials available that are actually looking for baseline data over a course of a couple years, essentially. So it's just assessments that we do in clinic. Unfortunately, there's no therapeutic trials available. However, we expect that to be coming down the pipe relatively soon, later this year. So if you're interested, I can give you my card. You can follow up with me later in the event that you would like to be involved with a therapeutic agent. So that was essentially it. And if you're interested in the longitudinal observational trial, I do have some informed consents that you can look over. I can give them to you. It goes over the complete auspices of what the trial entails, what's expected as a patient, what we offer in regarding to that trial. So if you have any questions, let me know. If you're interested, I can give you a card. Any questions? No? Okay.
Thank you, Gil.
Thank you.
I've already got the mic here. And then one more piece of information back there is what we call our ALS registry, and that's a national registry. It takes, 45 minutes or so to an hour to fill out, but there's information to take on that as well. So again, we appreciate you being here. I think we'll make that transition to Arlene, but let's go ahead and, for those that are hungry, I think that might be the next best step before we proceed. All right, thank you.
Good, Steve. How are you? Good.